That's 23135. We've had an additional 15 deaths notified to us in the last 24 hours, bringing the total now to 1,467, 60 notifications in the last 24 hours. Of those 1,467 deaths, 599 occurred in a hospital setting, that's 41%. 70 of them were in an intensive care unit environment, that's 4.7%. We've had reports of underlying medical conditions in association with 1,265 of those cases, that's 86%. The male-female breakdown is almost identical, 736 males, 731 females. The median age is 84, the mean age is 82. As of Saturday midnight, the 9th of May, just gone, 22,894 incident cases were notified to us. By then, 2,998 of whom had been hospitalised, that's 13%. 383 had been admitted to intensive care, that's 1.7%. 29.9% are healthcare workers. The male-female breakdown of those incident cases is 43% male, 57% females, and the median age is 49. In terms of intensive care, 385 in total admitted, the most up-to-date figure. 71 remain in intensive care. There were 2 new admissions to intensive care units in the last 24 hours. And just in terms of the clusters reported to us so far in association with residential care facilities, the number now stands at 425. That's an increase of 7, 244 of which are nursing homes, an increase of 3. The total number of cases associated with residential care facilities is now 5,779, 5,779, an increase of 72, 4,519 of which are in association with nursing homes. That's an increase of 50. The numbers hospitalised in respect of each of those, 428 of residents of residential care facilities, that's 7.4% of those cases, 301 of cases of residents of nursing homes, that's 5.2% of all nursing home resident cases. In terms of deaths, 920 are in respect of residents in residential care facilities, that's 62.7% of the total number of deaths, the 1,467 figure I gave you. 798 of which are in respect of nursing homes, that's 54.4% of the total number of deaths. And then finally, in respect of deaths in a hospital environment, they accounted for 18.3% of the deaths in respect of residential care facility residents. That's 168, 140 of which are nursing home residents. That's 17.5% of those. And I just wanted to give you one additional piece of information that I have on a graph. Magically, it'll come up, I'm sure, in the course of questions, and I'll deal with it then. Yes, no, it's here. I just want to point one thing out that we've just been watching in the last short while. This is a question that we ask of people as part of the twice-weekly market survey. We're asking people, do you feel the worst of this coronavirus crisis is ahead of us, behind us, or happening now? And if you just look at the blue line, we've seen a percentage in that the number of people, 43% it now stands at, of people who believe that the worst of this is behind us. So we think that's still a challenge for us in getting the message out, that in terms of the risk of what some people might call a second spike, but an increase in cases that causes a challenge for us, first of all in terms of public health, of course, but also in terms of an impact on the healthcare system, and happening quite quickly if, as it were, we get it wrong as we step out of the restrictions that we have. 43% is quite a high percentage of people who believe that this is over and the work is done here. So that's just a little cause for concern that we have. Richard.
Richard Chambers from Virgin Media News. Just on that graph, what is your message then to people who do think that we are coming through the worst of this? Is it that, you know, we may not have seen anywhere near the worst of this? This is something we have obviously been told by public health officials, scientists around the world, that we're going to have to live with for quite some time. There is every chance that the very worst of this is still ahead of us, isn't there?
So we've done a great job, as we've said, as a country in helping to keep this suppressed and to get the numbers down of new cases, with all the benefit that that has had in terms of limiting the impact on public health, first of all, but also limiting the impact on the healthcare system. I'm simply making the point that if we get it wrong, as we begin to ease restrictions, and we hope that we're moving towards a point at which we'll be able to do that, and we see the reproductive number of the infection rising to a level which is beyond what we think we can deal with or we can cope with, we could have a significant challenge with this that's every bit as great as the challenge we might have had we not gotten this as controlled as we did over the course of the last 2 months.
Is there a risk then, because speaking to cabinet ministers today, or a couple of cabinet ministers have come out and said that there is a chance we might speed things up, that if we make enough progress, you might see some retailers, for example, open up ahead of schedule. Is that not risking all the progress that has been made if there is a push to open more things more quickly than you would have intended?
We can understand that anticipation and that desire to see progress, and we share it ourselves. But we'll be making an assessment on a continuing basis of the public health case based on the disease and the transmission patterns and the other measures that we think are important for us to measure and to report on. And we'll make that advice available to government both this week and then at every 3-week interval we identified as we step our way through the course of the plan. And as I've said consistently from the start, we won't be recommending any measure by way of a restriction is in place for any longer than it needs to be.
Just in terms of next week, May 18th being the start of, or being phase 1, are our testing turnaround times good enough? Are our contact tracing measures at this stage good enough to do this? Is there a risk that we might not hit phase 1 or further phases down the line if we don't turn that around? Because you're still hearing from GPs today, some people waiting 7 days or even longer still for test results. Surely if that doesn't improve, we won't be able to make it through all of the phases as intended.
But look, we've seen significant improvement in that, and today isn't the day that we're going to be making the assessment. We'll do that over the course of this week, and towards the end of the week we'll arrive at an assessment and we'll make that advice available to government. What I would say at this stage, we think, and we're hopeful that we'll be in a position to make a positive recommendation in relation to those restrictions and all of the considerations that have to go into that for Monday.
Some concern across the country amongst the public about tourists perhaps arriving from the UK in the next number of months as lockdown restrictions are eased there. Should there be more done to try and regulate that? Speaking to Simon Harris, he says there will probably be more done at a government level. Is that something you are concerned about, that people might be tempted now that it's easier to get around in their own country, might be tempted to come over here for a holiday in the summer?
So we have recommended against all non-essential travel. We don't want to see that kind of travel happening at this point in time. Tourists are very welcome to this country, but not at a point at which we think the point at which we're in now. We have made some new specific advice available to government, as we said last Friday as a result of our NEFIT meeting on Friday, consistent with the advice that's in our advice that informed the roadmap, and that's all part of what government will be considering this week, and whatever measures then are taken will be informed by that and be made clear over the course of the coming days.
One more then, it's just in New York State, there's now been a regulation, there's a requirement now for nursing home staff and residents to be tested twice every week. Is that something we should be looking to implement here?
So the ECDC has, as you may be aware, in its 9th risk assessment made a similar sort of recommendation, and it talks about countries where capacity exists. We'll want to ensure that we have a continuing programme. I think we're one of the few countries, I haven't identified another example, that has done an exercise as comprehensive as the one we've just completed in the nursing home and residential care facilities. It did begin to identify, obviously, high numbers of cases in some of those settings that had reported clusters, but the positivity rate associated with the continuing programme of testing has fallen quite substantially. One of the things we want to now give consideration to is, while we believe we've made progress in slowing the rate of transmission in the nursing home sector, and we have evidence of that now, what is the nature of the testing programme that we need to now keep in place to continue to give us assurance that we're protecting that particular sector and that we continue to protect them as part of our ongoing management of this disease. Thanks, Richard.
Dr. Houlihan, good afternoon.
Afternoon.
We see from the maths here that the social distancing advice is that, keep at least 1 metre, 3 feet between yourself and others, but ideally at least 2 metres, 6 feet from one another. Can I just ask you, does that mean that 1 metre, 3 feet is okay? I mean, that could be the difference between a business opening and being viable and maybe not being viable. So is it the case that 3 feet is acceptable? That is what that means.
So we've settled on 2 metres. Those are on the ground a little while, as you'll see from the state that some of them are in from your, I don't mean your feet particularly, Fergal, but for just being walked on by all of us. and we did have 1 to 2 metres, but we gave some consideration to that as part of our public health advice. Our public health advice is now a 2 metre distance, yeah.
Is there anything, just going back to my colleague Richard, what he was saying, is there anything as of now that you would see that could jeopardise the reactivation of phase 1 on this day week? Is there anything you'd see it today?
Well, look, I'm not going to make predictions. I said to you that I'm hopeful. In terms of the track of the disease, some of the patterns that we think are important are giving us encouragement. We'll continue to monitor those over the course of the week. Were something untoward to happen, which we're not necessarily anticipating, we'd respond to that. Any of the times at which things we weren't expecting happened over the course of this illness, we have not hesitated to respond. But my hope, my expectation at this stage is that we might be in a position to make a positive recommendation in relation to easing of restrictions.
And in relation to a meeting of NEFIT tomorrow, I mean, what's on the agenda there? Will you be looking at masks again? I know it's an ongoing issue being considered for the public. But what else is on your agenda tomorrow for NEFIT?
So we have a few things. I mean, the regular things you're well familiar with at this stage. We monitor the path of the disease. We monitor the impact of all of the various measures that are in place and give consideration then to what further measures are in place. And there's some things that we give consideration to on a continuing basis, like travel, for example. So we'll give further consideration to that issue. We will give some consideration to the question of masks, although we've made, as you're aware, a recommendation to government that we do see a role for masks which are not of a healthcare standard. In other words, not healthcare masks for use in certain settings, and we'll be doing some work to try to sharpen up on precisely what those settings will be for the purpose of easing of restrictions and planning some of the general guidance that we'll issue to the public around how they can both find, use, and maybe in some situations make masks that will be useful for this purpose in the settings in which we recommend it. And that's for the most part the agenda tomorrow. We're starting to give some consideration to the nature of the measures that we might be recommending towards the end of the week, but we won't conclude on that tomorrow.
Thank you.
Hi, Tony. Shane Beattie from News Talk. Just wanted to check with you on the NEFIT meeting tomorrow. Are we expecting a decision on the testing of people in direct provision and also those working in meat factories where there's been clusters?
No, I mean, that's already happening. So as a result of our discussions towards the end of last week, which wasn't only the NEFIT discussion, to be fair, the HSE was already doing a significant amount of work with other organisations, for example, the Department of Justice in relation to direct provision, and some of those things were on the agenda. But we did say on Friday that the testing priority would move on from being nursing homes and residential facilities to some of those kinds of facilities that you're now talking about. And the team at the HSE and the public health team are planning the specifics of that in terms of, staff and residents and employees and so on. And that work is happening as we speak. Some of that testing has already commenced.
The figure of 455 cases combined Saturday and Sunday, like the last 2 days, new confirmed cases, were we expecting that? Were we expecting the figures? Did it cause any level of concern for you to have figures of 220, 230 in a day this stage into it?
I think, in fact, in relation to yesterday's number, there was, I won't call it an error, but there's an adjustment. There was an over-reporting in terms of some of the case numbers yesterday. So, in fact, the number for yesterday was a lower figure. I'd be corrected on the precision of it, but it was something in the region of about 170, am I?
That was corrected afterwards. There was, the figure was as went out in the press statement yesterday evening. So.
And what we tried to do is to explain whether, because there was a small increase, was that accounted for by testing or a change in testing practice, and we think it was.
And just on that issue of testing, you were saying to us on Friday here that we've had an effective doubling of GP referrals as a result of the widening of case criteria for testing. Cillian de Gascon on News Talk yesterday said we've seen a small increase in GP referrals, and it's not overwhelming the system by any stretch of the imagination. I know you'll tell me it's not overwhelming it, but a small increase wouldn't be the same as saying a doubling of GP referrals.
I didn't hear what Cillian said, but we know that that's what the data is, that in effect between the two changes, in other words, the broadening of the clinical case criteria and the removal of the prioritisation criteria, it has produced in and about that change in the number of referrals, which to begin with wasn't very high relative to the available capacity. And I'm sure that Killian's reflection was essentially saying that, reflecting on the fact that it was us being able to confirm that we're nowhere close to that having, if you like, breached or caused a challenge in terms of the total available capacity, which I think was one of the concerns that we all had. Like when we broadened that case definition to make it as wide as possible and remove the prioritisation criteria, would we be inundated or overwhelmed by the volume of responses, and we haven't been.
And just one final thing for me, some of the Sunday papers were saying yesterday that we could be detecting as low as 1 in 10 cases in this country. Is that your suspicion?
I have no reason to believe that that's the case. You know that we make an adjustment in terms of the model that accounts for the fact that, yes, we don't think that we can say we're detecting every single case that's occurring in the community. We make an adjustment of around 50%, and we've talked before about the possibility of one case not identified for each case that occurs, which is why we need to remain vigilant about the possibility of transmission. Not every case, as I say, we can expect to detect. There have been some reports in the literature suggesting that some of the rates of asymptomatic transmission, in fact, might be much higher. The number of asymptomatic cases, in fact, might be much higher. We'll really begin to understand this properly when we have a properly validated serology test that allows us to do blood samples on people and can identify what percentage of the population has actually had exposure to this disease. That'll be the one reliable way that the world will have of answering that question. But the serology studies so far that have been done are small and the data not reliable enough for us to draw, let's say, definitive conclusions on that. But we're hopeful that won't be too far away at that point.
Great, thank you.
Thanks, Shane.
Mark Coughlin from Primetime. Hi, how are you?
Good.
Wednesday, Thursday and Friday I came and asked for information on basic metrics for how long it takes a swab to be processed into the testing system and so on and so forth, and all the way through to contact tracing. You said on Thursday it will be available, Friday. On Friday it might be available. Monday, is it yet available?
So we have something, David, you might be in a position to share something of the HSE's current, and it is a situation which is an improving one, just to bear that in mind, yeah.
So as of today, the median time from start to finish on the process is 5 days. So meaning that there are some that complete quicker than that and others that are beyond that 5 days. And I think that's reflected in what we heard this morning. But that's an improving figure. And with further automation of the return of negative results starting today, that should cut about a day off the median, but there's still work to do on that in order to compress the timeline down to the target, which is 3 days or below. So, but it has improved. The median is now 5. We need to get that down further. We'll have it down further by the end of the week, hopefully to 4, and then try and improve the process more to get it down to the target time frame.
You clearly have data there. Can you publish that data? We haven't been given it here at the press conference.
I've just given you the data I have, which is around the median time.
Presumably there's numbers behind that.
Yeah.
So
I don't have it in front of me, though. Yeah.
I think it would be appreciated if these numbers could be made public on a regular basis, as I've asked several times. And obviously there is tables behind the median number, so would it be possible for you to publish those numbers on a regular basis?
I'll go back to the head of testing. My understanding is that the figures are compiled now on a daily basis. So, yeah.
Okay.
I mean, if I could just add to that, it's an important point, not to deflect what you're asking. There's also a potential improvement if people with symptoms respond earlier. And the earlier that they respond, the quicker we have, the better the chance we have of obviously affecting an earlier diagnosis. That all contributes to the chain, if you like, of knowledge. And for people to understand now that the length of time that they will have to wait is much shorter, that there won't be long queues, there won't be long waits if they come to their GP, so they'll get referred and sampled and a result back much more quickly. And responding, I think, and I'll check this, but a number of days elapses, and I think it might be close to an average of 4 days or so between the point at which on average, where a person experiences symptoms and then the specimen sample is actually done. So there's clearly a period of time there that's important that can be shortened by people, let's say, at an earlier stage. So our message would be, if you're experiencing these kinds of symptoms, don't wait until tomorrow to see if they go away. Come today or make contact with your GP for testing. and remember the basic public health message, which is to self-isolate for the 14 days until such time as you've had a test and the test result either proves positive, in which case it confirms, or until such time as if you have a negative test, you're then symptom-free for 48 hours.
These are new numbers, and obviously I'm operating somewhat blindly in that I don't have the actual parameters that you've used to calculate them, but could you give us a bit more detail as to where it covers up to in terms of dates, and some detail as to the number of tests involved? Does it include all types of tests? Does it include the hospital tests, community tests? Could you just break it down a little bit more, because we obviously don't have sight of it here?
Yeah, as I said, I don't have that detail in front of me, but absolutely, when you look at hospital tests, they're probably the quickest turnaround, and then the laboratory ones are probably a day longer in terms of just going through that chain of getting them there and getting them processed and back, and then that's as I understand it, the time at laboratory was probably in around 3 days last week. That's been compressed on average to about 2 days this week, but the hospitals still remain quicker. The hospital laboratories still remain quicker.
And a final question, if you don't mind, because these are figures that I haven't seen. So, do you have figures that include from start to finish, including contact tracing? Am I understanding you correctly? You're just talking about tests here.
No, the 5 days is end to end to commencement of contact tracing.
So the 5 days is from when a swab is ordered to when a contact tracing is completed. Commences. Yeah. Do you have a number for approximately how long contact tracing is taking?
I don't within these figures.
Thank you.
I mean, just to point that out, though, Mark,
Sure.
that'll be a function of the complexity of a contact tracing, which will depend on the case.
Sure.
If an individual has followed public health advice and has stayed at home and self-isolated, you'll be talking about a very tight number of household contacts and a very rapid interview. If an individual, and unfortunately there are individuals where contact tracing is done of an individual, and if they haven't been following public health advice, they may have had a large number of contacts, and the process to identify those and deal with each one of them takes a lot longer.
Just to follow up that briefly,
Sure.
and I apologise to
No,
the
no,
press
that's
officer. Is the information that you are receiving, is it sufficiently real time to base decisions upon at the moment?
I think it is. I think that the experience that David is setting out here reflects experience that is live for the last week. It's not like experience of weeks ago. So this is the real-time experience that we have at the moment, and obviously the plan is to continue to improve that. And I think within that, as you're asking, and you're right, the turnaround within hospitals is very rapid. So like people are getting hospital tests as quick as you could ever get hospital tests. They're done and they're reported as quickly as the process of doing this test. It's a 6 to 8 hour, the PCR test, something of that order, will allow.
Thank you, and apologies to the ISL signer who had to continuously do that.
Thanks, Mark.
Hi, Tony. Conal Thomas from the Journal.ie. Speaking on Sunday, Dr. Colm Henry said that transmission among asymptomatic cases is actually, I suppose, a greater risk than they may have first thought. I think he was specifically talking about older people in nursing homes. So I'm wondering, does this affect the way we look at the figures? So, for instance, could case figures therefore be higher, and could it affect the R number?
No, I think it's taken into account in the modelling as much as we understand in terms of the modelling assumptions, and it takes account of that potential. And of course, the modelling is based on observed cases. And I didn't hear the remarks that Colin made, but I know what he would have been talking about. In nursing home environments, it can be the case that people present in ways that are a little different. There is a challenge with older people, as there is with many diseases. They present often atypically or in unusual ways. And sometimes it can be the case that a case is reported as asymptomatic because you don't have the classic symptoms that we're describing here, but actually if you go back in the history of a person, they have some maybe less common or unusual symptoms that can be attributed to this illness. But we know now much more than we would have known, say, going back at the very beginning of this, when we were only dealing with the reports from China, that asymptomatic transmission is an important part. And what that will do is it will inform our strategy going forward around testing and contact tracing. So the contact tracing process now already begins from a point 48 hours prior to the onset of symptoms. That takes account of that known fact. And then we plan to introduce not only a contact tracing interview and a follow-up with the contacts, but a testing regime for contacts as well, that we might be able to identify people who have been infected, who are incubating the virus but haven't yet developed symptoms, to pick up on exactly that risk you're asking about.
Can I ask you about transmission within the community? Are the figures still high? And if they are still too high, what are you attributing that to?
Well, they're high in the sense that, like, for a significant percentage of the cases, even though the number of cases is much smaller, identifying how that person became infected is the challenge. And so we see that transmission in the community where you can't identify, that accounts for still a substantial percentage where we know the status of the infection. It's been attributed to essentially a wild infection. A person, when you interview them, is not able to report a contact with a confirmed case to say how they, as an individual, picked it up, and yet they're confirmed. So they've picked it up somewhere.
That's a significant amount of cases, is it, you mentioned?
In percentage terms, it does account for significant numbers. It would be the majority of cases, it would, but it's a falling number. So we know the number is falling, so clearly the chance of you picking up this infection is reducing. And we know that's the case from all of the parameters we monitor. But nevertheless, we're not able to attribute the infection to a particular exposure. If you go right back to the early days of this, we were able to identify how a particular person picked up this infection, either because of travel-related or because of contact with another known case. But as we went on, we began to see the phenomenon of what we call community transmission. But the amount of it in total, although the percentage of cases is high, the total amount of it has reduced very substantially.
Finally, Tony, can I just, it might be one for yourself, Brita, about direct provision centres. Can you provide a little bit more detail in terms of, how you are going to ramp up testing in centres, whether it's going to be earmarking larger centres with greater residents, or how exactly it's going to work, and how does that feed into communicating that with the Department of Justice and vice versa?
So we have seen a number of outbreaks in direct provision centres, and each outbreak is evaluated, and a risk assessment is made on each outbreak. So for each risk assessment, then it is decided on the testing strategy within that direct provision centre. So this is a case-by-case mechanism. It's like any outbreak investigation. The public health approach is a risk assessment of each particular scenario, and to identify the contacts involved and to carry out the appropriate public health measures to deal with that situation. So that's how we're approaching the direct provision centres at the moment.
Okay, thanks. Thank you.
Keenan Brennan, Irish Examiner. I'll be fairly brief today. I was just wondering if last Tuesday the figure for contact tracing outside of public health was 40. I was just wondering if you could tell me what the figure is at present.
I don't have the precise figure, but it's not going to be wildly different to that, I would think, because the total number of cases that require that contact tracing is small, and that's what determines the number of people who are deployed into contact tracing at a point in time. All the complex work, for the most part, has been done by public health doctors, but that number there related to people from the contact tracing teams, who are not public health doctors, where they do the less complex cases, as I say, and it's a function of the number of those cases we're diagnosing, which is much smaller now in these days than it was earlier in the epidemic.
It's been speculated that the average for a contact tracing, like an individual one, is about 4 days. Is there a basis to that, or could you give any indication?
The more straightforward ones, as I say, are faster than that. They're more straightforward interviews. I don't have precise data on exactly how long they last, but they would be shorter than 4 days, because the average case, as I say, is household contacts, and on average still a median or a mean of something in the region of 2 to 3 days or people rather, at the most.
And David, you mentioned that the timing is now 5 days. Was that from referral to contact tracing beginning? Yeah, from referral.
That's right, yeah.
Okay.
Yeah. That's the median time, yeah.
So how low really could you hope to get that figure?
Well, with the automation that's starting today in relation to the negative tests, I mean, that will bring back the reporting by an average by a day. And then every point in the chain has been examined to see can that be compressed. And more importantly, as the Chief Medical Officer said, if people present earlier with their symptoms, the overall outcome of the process will be more valuable.
Finally, and this one's sort of anecdotal, but I know of 3 people recently who were very sick in a way they're not used to being sick, who strongly suspected they had it, who got tests, I think about 7 days was the average, but they got their results back. All were negative. Is this some sort of trend that's being seen, or I mean, could people be in some sort of psychosomatic way be thinking they have something that they don't have, or are negative results just negative results that aren't correct? Are they something that has to be worked into any model?
So the symptoms that we're talking about, they're common symptoms, they're shared by other illnesses. That's the first point. So other illness, even though we're at a time of the year where the background rate of respiratory viral illness is not high, we don't think there isn't influenza, for example, circulating, but there are other types of viruses that can cause similar patterns. The suggestion you're making in terms of psychosomatic, yes, of course, that can happen. But again, we think where the public is at the moment, there was a lot of worry, for example, back in the early days of March, and when we changed case definitions and so on, there was a lot of help-seeking behaviour that we know didn't relate to the disease and the actual numbers of infection that are out in the disease, are out in the population, I should say. So we don't think this is happening to a great extent. Couldn't say it doesn't happen. And when people are symptomatic and when they have their most intense symptoms, that's when the test is most likely to be positive. You can have negative results when people are incubating the virus, and the viral load, as we call it, in the body isn't such as to generate a positive result, which is why we do not overinterpret a negative test. A negative test means that a person doesn't have the virus. The virus wasn't identified at that time in that test.
Thanks very much.
You're welcome.
Good evening, Neil Leslie from the Mirror. Just on the public health advice in the roadmap allowed for team sports to resume. I think it was phase 3, while social distancing was obviously still a feature in society at large. I think it said the public health rationale is that the need to balance social distancing with physical, cultural, social needs. The GAA president obviously last night came out and said they weren't kind of prepared to play while there was still social distancing being practiced in society. Were you surprised at that view they took?
No. I mean, they've looked like we advise every organisation now to internalise, if you like, the public health advice that we give, to come to their own assessments, which won't just be the public health advice, but maybe other questions around feasibility and capacity to organise and run events of this scale and of this nature. And I know a good bit about the GAA, but not at that kind of level in terms of the organisation of sporting events. So I wouldn't say that I was necessarily surprised. That's how they felt as an organisation they should respond to the advice that we're giving.
Specifically, you felt team sports could go ahead while social distancing was a feature in society at large. That wasn't an issue in the...
So there are different stages in all of this. So you could be talking about team events that involve small numbers at a club level, small attendance and so on. But as you step all the way through that to the kind of events that we associate, the elite level sporting events in the GAA, inter-county games, sure, where you have large attendance and so on, that's something different again.
I think they've taken the view that nothing should happen at all, including the smaller club events. But as I say, the public health advice wasn't to that extreme, was it?
So, as I say, we've set out the advice and they've made their assessments based on that advice, and I'm not going to criticise the GAA, I can tell you.
Okay. Just the testing and tracing regime, then we're expected to get it to 4 days by the end of the week, from what you've said this evening. Then is that going to be good enough to ease restrictions on the 18th of May?
Oh, sorry, I thought you were looking at David there. Apologies. I think we're seeing, so it's not a static thing. We're seeing continuing improvement. A huge amount of work has been done, to be fair, in the HSE to build what is an enormous programme of testing, of sampling, of contact tracing, of follow-up of contacts and so on, to get it fit for purpose and putting in place the IT automation. It's an enterprise and a scale that has never been built before in any country, and it's continuing to improve. So there's more work to be done. There'll be more work to be done over the course of the remainder of this week, as David said, to take steps out of the process to make it as flexible and as fast as possible. We're not just looking at that, we're looking at the disease parameters. And at this point in time, I have no reason to believe that when we get to the end of the week that the testing capacity and sampling and contact tracing arrangements in the HSE will be a reason to hold us back in terms of any decision that we make. But that is not the only factor.
Okay, and sorry, just briefly on the, I've seen the number of deaths thankfully come down, even though there's still a number of tragic deaths today. Do you have the chart with the actual dates?
I do. And just bear in mind when I say that there is always a weekend effect in reporting. Things don't get reported at weekends or on Sundays as much as they normally would be, so just don't overinterpret it. But those are the deaths that we report today, the 15 identified by the date on which death occurred. And broadly speaking, it's following the same pattern that most of them relate to the last few days. But there are a number there, as you can see, going right back to earlier days. Just to say, these bars are not very high. The highest of them all is 4. So the greatest number of deaths in any individual day was 4, which was on the 8th, which was Friday, I think.
Would that be one of the lower figures that we've seen from the start of the outbreak?
Yeah, it is a low number. It is a low number, yeah, in relative terms, and it feeds into this view. So this is the chart now with all of those extra deaths and the total number of deaths that we've had identified. And just again, you know this at this point, that this is both laboratory confirmed and probable cases. All the cases we could identify, irrespective of where they've occurred, which makes us different to many other countries. Shown according to the date in which they occurred. And again, just to remind you that the red ones are to show that there could be a little lag in reporting. So deaths that occurred today, for example, we won't hear reported until probably Wednesday or Thursday of this week. This is the cumulative number by date of death, the total amount, in other words. And you can see that the graph has slowed substantially towards the top. It has flattened out, and that's the percentage daily growth. A 5-day moving average to show that the trend is downward, 0 being the baseline. It's dropped continually since the peak at around the end of March.
Okay, thank you.
Thank you.
Hi, David Quinn, Sunday Times. So the percentage of overall deaths that have occurred among community residents community care residents is about 60%. Do we know what the percentage of deaths among care home residents has been in the past week in terms of the overall number, if that question makes sense?
So of all the deaths in the last week, many of them were care home residents.
Yeah.
I don't have that figure for me,
okay.
Right? I don't have any reason to believe it's substantially different, but the number in total for, I could calculate it by going back in my pages here, if you have the patience to wait for me to do that, but the total precise figure is 62.7%. As of now. So of the 920 deaths that are in relation to residents in that sector, that represented 62.7% of the total number of 1467 that we've had since the beginning.
And you don't think that percentage has been increasing as you know, because obviously the number of deaths has gone low compared to what it was. So as the percentage among care home residents gone higher as an overall percentage of that lower number, if you catch my drift.
No, I do catch your drift, absolutely. I mean, one of the things that we'd like to know that would give me greater precision, if you like, in terms of answering this, would be to know the full reporting experience in relation to deaths that occur in the community. And what we depend on then is that for those is notifications to the GRO. The law provides for a 3-month time period, which is in relative terms long by international standards. If we had earlier reporting on that, I'd be able to tell you that we have more comprehensive understanding of. So undoubtedly there are deaths that will be in the community that haven't yet been reported to us because they're not delayed in terms of that notification time period. And one of the things we've been doing to try and deal with that since the start is encouraging earlier notification and reporting, pointing out that the GRO has made available an online mechanism for families, even at this difficult time, to notify deaths online. And we want to encourage people to do that quickly. And we also wrote to the funeral directors to encourage families in these circumstances and to raise that question and to point out that the GRO has now, as part of its innovations, made a mechanism available that avoids people having to go into an office to do the registration, that they can do it online. And so we want to encourage in as much as we can, as early and near to the point at which the death of an individual occurs, reporting, so that we then know that we're getting these reports in a timely way. And that's the question that would feed into this whole, you've heard us talking about excess mortality and the monitoring of that trend across the whole population. We do participate in that at both the national level and feed into the European measures on that. And we know that the level of reporting is telling us that maybe we're not seeing all the notifications happening at the level that you'd normally expect to see in the population.
Okay, and the second question is, when Professor Nolan last week was talking about the reproduction number having dipped considerably below 1, does the present figure, I think, was about 0.5,
yeah.
Does that include the cases among health workers and care home residents? So if you take them out, what's the reproduction number?
Yeah, no, it does.
It does include them?
It does. And actually, in population terms, they'll have a relatively small effect, although they're large numbers, because the percentage of them, if you like, they represent a high incidence in the environment in which they occur. But played into a whole population number, they're in relative terms a small number.
So therefore, if you take them out, the reproduction number doesn't go down too much?
Yeah, I'm not certain. I'm not saying that they have done that and look at the reproduction with them or without, but it includes it's based on all of the cases that have occurred. Yeah.
Okay, thank you.
Yeah, thanks, David.
Robert Hanrahan, Joe.ie. Can I ask, we saw today and from last night that England are now staying alert rather than staying at home. Are there concerns about the common travel arrangement and the potential for the mixed messaging in the UK to maybe bleed into our response here?
So you mean...
So what I mean is, sorry...
No, you mean the UK rather than England, I presume, is it?
As a whole, yeah.
Yeah. So no, we've been hearing that and we've been studying that. And we'll give consideration, if you like, to the ongoing assessment that we have here relative to there, if we think there are any differences that arise in terms of the measures. They've only just published the plan today. We'll be giving some consideration to that tomorrow as to whether that has any particular travel implications that arise for us vis-a-vis people from across Great Britain. So that's be part of our work tomorrow.
Okay. Yeah. And can I just ask, I raised this on Friday about a letter that was sent to direct provision residents in Cahersiveen that blamed them for the continued outbreak in the Skellig Star Hotel. We were told we would have clarity on this. I know Dr. Nereen isn't here this evening, but we contacted HSE separately as well and are yet to receive any response. Do we know if that letter came from the HSE or not? Because it is titled as being from them, but it's not on HSE letterhead.
I know I've seen the letter. I don't have details as to whether or not it came from the Department of Public Health locally. As I said, it's not on a letterhead, so we are seeking to clarify that. So you will get a response on that.
We're still unaware whether it came from the HSE or not. Is that correct?
Well, I'm not from the Public Health Department, but I did see the letter. It was sent on to me this evening. And it did say it was from the local Public Health Department. But I mean, I think to be fair, I think it was stating that, in the opinion of the author, that the isolation measures weren't working. And I think that was...
That the isolation measures weren't being followed. And sorry, the reason I ask is just the tone and the language has been, as you've seen it yourself, it's quite accusatory and has been labelled as being unfair by the residents themselves, so they just simply can't follow what's been set out for them. And it is either from the HSE and has that tone, or it's the Direct Provision Centre or someone else who are using the HSE to communicate their own message is the reason why I'm following up.
And I think I'm committing to clarify that for you.
Thank you.
Hi, Paul Cullen. We've done blanket testing of nursing homes. It's finished, I think, isn't it?
Yeah. As I understand things effectively, yes, it is finished, yeah.
What's the position on what I call blanket testing of other long-term care settings?
So the question of other long-term care facilities is the thing that's been considered. I was referencing earlier on.
Well, that's including the meat factories and the other places.
And direct provision and homeless and prisons and other such locations as to what the testing strategy should be. It's not necessarily an automatic decision to test everybody. It'll depend, because it's an outbreak situation, it's the particular experience of infection in an institution at a point in time that dictates. So if you think back to the nursing homes, the prioritisation was that where there was a cluster, test all the residents and staff in that facility, or where a new case arose, test all the residents and staff in that facility. But where there hadn't been a cluster previously identified and there was no reports of infection in those centres, the next priority was to test the staff, and then depending on what that identified to go. So there's never just a blanket. It depends very much on what the status of infection is in each of those places. That's the point I make.
In the other long-term residential facility, if there's no cluster, who gets tested? If there is a cluster, sorry, let's say, if there has been a cluster, does everybody get tested?
So that would have been the practice, yeah. That if there is a cluster, then we test all the other residents and the staff.
And then if there isn't a cluster?
And if there is no cluster but a new case is to appear, then that was also the position, that you would test all the staff and the patients. And then in another facility, if that had previously no reports of either cases or clusters, you would start with the staff. If you identified a case among the staff, then you would proceed to test the residents. But
Just
if you didn't,
the Mental Health Commission seemed to think that there was going to be testing. They said the original plan would have seen all staff tested irrespective of whether there was an outbreak in the unit or not. Is that your understanding?
That's what the Chief Medical Officer has said in that.
Sorry, I'm trying to ask questions, read things, and
I
maybe I'm not
understand.
listening.
So if you look at the mental health centres, as of yesterday, the plan was to finish testing staff and residents where there had been outbreaks or suspected outbreaks, and then by the middle of this week to complete testing staff in the other long-term care centres. So that should be completed by midweek of this week, which is in line with what the Chief Medical Officer has just said, that where there's no evidence right now of an outbreak, then test the staff as the first measure. Yeah.
Okay. And just one other question. Masks, I know you haven't formulated your recommendation, but will the recommendation be for compulsory or optional wearing of head coverings of whatever form you decide?
Well, we'll give formal consideration to that, but I'm not anticipating that we'll be making it mandatory.
Maybe a recommendation.
A recommendation to the public, and what we've seen so far in terms of the public behaviours, and I've shown you, albeit different data, in respect of hand washing, so on, the levels of compliance that we're having from the public in terms of the basic public health message is very high. So then I'd be confident that if we made a recommendation, we'll get good levels of compliance.
Thank you.
Thanks, Paul. I have just, David, if I have been doing a little bit of going back on just the last few days as we calculate these. So the percentage of mortality that is accounted, of the total mortality that's accounted for by residents of residential facilities has been rising slightly, if that makes sense. And that's driven really by the fact that we're identifying mortality, we're doing so in mortality among the residential care facilities as rather at a greater rate than in the general population, if that makes sense to you. I can't hear the question now because you're not near the microphone. What is the percentage, is it? Yeah. It's gone from, like, say, a week ago, I'm just checking back on my own notes here. I write these figures down each day as I give them to you, as you know. So it was at about 58% about 8-10 days ago. And it's risen up to the low 60s and is now at 62.7%. So it's gone from high 50s to of the total number. Yeah. I can pull. We can do that analysis more if you want. If you're interested in it, and do it. And give you something tomorrow on that if you wish.
Thank you.
Yeah. Okay. Thanks, David.